You are now listening to Appointment, a podcast dedicated to showcasing the very best direct primary care providers in your community. These guests are taking the initiative to transform how you receive your healthcare services by simplifying the process and improving how healthcare is done. Appointment is sponsored by AppAccess, helping independent healthcare providers and entrepreneurs take control of their online presence by better engaging their mobile audiences no matter where they are. Learn more at AppAccessLLC.com. I am your host, Jonathan Christopher, and let's get started. In today's episode, I introduce you to Dr. Chad Savage. He is a physician at Your Choice Direct Care in Brighton, Michigan. And we're going to break this down into 5 parts of this series. This first part, we're going to be discussing his background and his motivation for practicing direct primary care. Let's get started. So today, guys, I want to welcome a special guest, Dr. Chad Savage, who is a physician at Your Choice Direct Care out of Brighton, Michigan. And he is a very vocal and active direct primary care advocate, and I'm so pleased to have him here to speak with us today. Dr. Savage, why don't you go ahead and tell us a little bit about yourself and how you got into DPC?
Sure. Thanks, Jonathan. Really appreciate being on. So I was actually an insurance company doc or insurance paid doc, I have to say, for about 13 years. And in the 2000s, there was a lot of recognition that something was broken in healthcare, and it started really coming into the political sphere. At first, I was actually really excited about that because I knew something was wrong, and I was excited people were going to try to do something to make it better. The unfortunate truth is that every step that was taken to theoretically make it better seemed to have the counter effect, at least in my practice. There were things like patient-centered medical home, which you may be familiar with, which I was thrilled about when it first came about, and actually a big proponent of, because it at least in its idea, and circled around how I wanted to practice, with the doctor and the patient functioning as the hub of this of the healthcare system, working together to collaborate on good healthcare. But as I found as we implemented it in its various stages, that each rendition of the new implementation actually was taking more and more time away from the patient, which seemed to be the exact opposite of what the intent was. So finally it got to the point where I was seeing 30 patients a day running room to room, and not only was I seeing that many patients, but a lot of that time was dedicated to filling out paperwork, and they have what they call the pajama hours, where after work you're at home and you're still charting well after the day has ended. And even on vacation, I could never feel like I ever actually got to take a break, because even on vacation I was charting and working and just trying to keep up with the mundane tasks that actually had very little to do with the patient care. So I started kind of to be honest with you, I started burning out on medicine, and this is something I dedicated my 20s to, giving up the best years of my life to become a doctor, and I always felt it was a noble profession and a great profession. You get paid to take care of people. It's a pretty sweet job, but I didn't feel that way anymore, and I was realizing I was in my early 40s, late 30s, thinking about retirement, like how soon I could retire, and I thought that this is bad. I should have decades of function left in me to help people out. So I started looking around, and I found out about direct primary care. And at that time, I'd already been trying to envision, if I did something outside of the system, how it could be done. So I was glad to see that other people were in the same mindset. And Josh Umber and Lee Gross and some of the others had really come up with this very clever system, which initially I didn't totally agree with initially, because it was a membership model, a monthly fee for all the medical care that you could consume basically from the primary care office. And I thought it would be abused. There'd be a lot of excessive utilization. But then when I started looking into it more and more, it really made sense, because it allowed for people to not have that initial hurdle to accessing medical care, which has clearly been shown to limit people's use of medical care. If they have to pay a ton of money to come and see the doctor, not surprisingly, they don't tend to access them as much. And then when that occurs, they eventually come in, but they're much sicker, end up in the hospital and with bad outcomes, which is a nice way of saying they get sick and sometimes die. We should not paint over, just say bad outcomes and say this is horrible, this is people suffering. So we figured with this model, you limited that, I mean, sure, the people do see us more. There's no doubt about it. They don't have that inhibition to come in to see us. But if we got compensated at a fair level and we worked for the patient, which is imperative, the incentives aligned, and we were able to take great care of people. And boy, oh boy, did the floodgates open when I went to this model. I realized all of the pent-up demand in at least my community for medical services. People had questions all the time that they just wouldn't ask, or maybe they'd go to Dr. Google and scare themselves half to death looking all around because they didn't feel that they didn't want to spend $160 to ask a doctor about that line down their nail bed or something of that sort. But then with our model, they said, "Oh, I don't have a problem." They take a picture of their cell phone of whatever, the line on their fingernail and say, "Hey, what's this?" "Oh, that's nothing," or "Hey, that's something to be worried about," and they got some instant gratification and relief for something that otherwise would have caused them consternation.
Mm-hmm.
So yeah, I loved it. I don't know if I'm answering your question kind of off on a rambling.
No, definitely. I actually very much enjoy the aspect where DPC kind of harkens back into more simpler, medical, practice modals or models. But in addition, the forward-looking aspect with regards to, like you said, using the cell phone to take a picture and, integrating telemedicine and just addressing things that wouldn't require an office visit, or at least is not emergent, in that sense. But I really like that draw. I've seen that on a lot of different websites that a lot of doctors are going that way.
Yeah. And I mean, everybody's recognizing the advantage of telemedicine. The problem is figuring out how to value the doctor's time when doing it. A lot of people say, well, I can call or text my doctor right now in the insurance model through their portal system. But with rare exception, that usually is kind of lackluster response. I hate to say it, the reason why is those doctors aren't usually paid or are very poorly paid for use of their time with that. So those are usually used to drive office visits where they make most of their money. So they say, oh, you got a problem? Well, here's some 2-cent answer, come into the office. So it's just another way of saying come into the office.
Right.
In our model, we are not paid more for them being in the office. We are not paid more for dealing with things through telehealth. So we're able to do it whichever way is appropriate to do for the patient and is medically appropriate too. Because there are some things where you really shouldn't try to manage remotely.
Exactly.
But now when we tell that person, hey, you need to come in and be seen, they no longer, and we used to be accused of this, they no longer are thinking, oh, you're just after my copay or something of that sort. They know that we don't get paid a dime more for them being in the office, and we tell them to do it. We're telling them out of true necessity.
Yeah, that's wonderful. So yeah, as you can see, I'm very excited to be speaking to Dr. Savage. We have 4 more parts coming up. If you want to listen in on those parts, be sure to subscribe to Appointment. The show can be found in many locations, including iTunes and Spotify. And we are definitely now on Amazon Alexa, and you can catch us in the flash briefing. So this is big time. So be sure to subscribe to the show, and we can hear more about Dr. Savage and direct primary care and how to move forward with it as we try to solve and address some of the healthcare issues with regards to insurance and expense that healthcare can burden us with in the United States. So again, 4 more parts, and I look forward to having you all join me in the discussion, and we will talk again next time. Bye.